Look at this model of the human heart in action. Digoxin presents a unique pharmacological paradox. It acts simultaneously as a positive inotrope, an agent that increases the physical force of muscular contractions, and as a negative dromotrope, a drug that slows the electrical conduction speed through the AV node. In the intensive care unit, this dual action fits a highly specific clinical profile. It is deployed for patients in atrial fibrillation who also present with hypotension, or those suffering from HFERF. HFERF stands for heart failure with reduced ejection fraction, meaning the left ventricle lacks the mechanical strength to pump adequate blood. Standard rate control agents, namely beta blockers and calcium channel blockers, depress blood pressure. Administering these to a hypotensive patient risks immediate cardiovascular collapse. Digoxin controls the heart rate without dropping the blood pressure. This efficacy comes with an exceptionally narrow therapeutic index. A slight dosing miscalculation quickly triggers lethal toxicity. Safe administration of this drug requires abandoning rote memorization of dosing tables. You must master its underlying biophysics. Predicting digoxin's effects means tracking the cellular mechanics that dictate exactly how a therapeutic dose tips into a lethal one. To trace that line between therapy and toxicity, we have to scale down from the systemic heart to the microscopic surface of a single cardiac myocyte. This diagram shows the myocyte cell membrane. At baseline, the Na+, K+ ATPase pump maintains normal cellular resting potential. This enzyme continuously pumps sodium out of the cell while pulling potassium in. When digoxin is administered, it binds directly to the Na+, K+ ATPase pump, completely freezing its function. The immediate consequence of this inhibition is a rapid, continuous buildup of intracellular sodium ions. Further down the membrane is a secondary transport mechanism called the NCX. The NCX is the sodium-calcium exchanger, a membrane protein that normally relies on the sodium gradient to remove calcium from the cell. Because digoxin destroyed the standard sodium gradient, the driving force for the NCX disappears. The exchanger stalls and reverses its normal operation. This reversal traps calcium inside the cell, causing a massive intracellular accumulation. Calcium is the direct catalyst for muscular contraction. High intracellular calcium aggressively enhances actin-myosin cross-bridging, the sliding filament process that shortens muscle fibers. This enhanced cross-bridging translates to profound positive inotropy. The heart muscle contracts with increased physical force, providing direct symptomatic relief for patients with HFrEF. Digoxin's mechanical benefit in heart failure relies entirely on weaponizing a microscopic ion traffic jam to force a failing heart to pump harder. Beyond the single cell, we must examine how digoxin affects the systemic neurological wiring of the heart. This wiring diagram illustrates digoxin's secondary mechanism. The drug increases central vagal tone. Vagal tone refers to the activity of the vagus nerve, which regulates the resting heart rate. Augmented vagal tone directly suppresses conduction velocity through the AV node, bottlenecking the electrical signals before they reach the ventricles. This AV nodal blockade provides essential rate control for patients experiencing the rapid, erratic atrial impulses of atrial fibrillation or atrial flutter. There is a critical limitation to this mechanism. Rate control via the vagus nerve depends entirely on the dominance of the parasympathetic nervous system, the body's rest and digest network. Contrast that resting state with the hyperadrenergic reality of a patient in septic shock, acute ICU stress, or high physical exertion. This overwhelming sympathetic overdrive completely neutralizes digoxin's vagal effects. The drug loses its grip on the AV node. Administering digoxin for rate control in a highly stressed or septic patient shows a misunderstanding of its autonomic limits. It only controls rate at rest. Translating these biophysics into practice requires adhering strictly to digoxin's unique pharmacokinetic timeline. This Cartesian graph plots serum digoxin concentration against time in hours. The standard IV loading protocol, called digitalization, requires 0.5 to 1.0 milligrams total. It is delivered as a slow push over 10 to 20 minutes under continuous ECG monitoring. The onset of action begins at 30 to 60 minutes, but the peak physiological effect is heavily delayed until 2 to 6 hours post-administration. Following the loading dose, maintenance requires 0.125 to 0.25 milligrams daily. The decay curve stretches out due to the drug's remarkably long 36-hour half-life. This band represents the razor-thin therapeutic window for heart failure patients. Safe serum levels sit strictly between 0.5 and 0.9 nanograms per milliliter. Because of the delayed peak, serum levels must never be drawn before 6 hours post-dose. Testing earlier captures undistributed drug in the blood, yielding a falsely elevated reading. The primary bottleneck for clearing this long-lasting molecule is the kidneys. Reduce the dose for the elderly, patients with low body weight, and anyone with renal impairment. With a 36-hour half-life, ignoring a patient's renal function guarantees toxic, irreversible accumulation over subsequent days. Urgent, precise tone. The most common preventable trigger for acute digoxin toxicity in the ICU is electrolyte derangement. Look back at the myocyte membrane. Extracellular potassium and digoxin exist in a state of structural competition. Potassium and digoxin have equal affinity for the exact same binding site on the ATPase pump. In a state of hypokalemia, the drop in extracellular potassium removes the competition. This allows digoxin molecules to swarm the receptors unopposed, causing massive cellular blockade. Because this toxicity is driven by competitive receptor binding rather than sheer drug volume, a patient can suffer life-threatening toxicity even if their serum digoxin levels read as perfectly normal. This graphic details the non-cardiac warning signs of toxicity. Patients present with gastrointestinal issues like severe nausea and anorexia, followed by neurological symptoms including delirium and xanthopsia. Xanthopsia is a visual disturbance where objects take on a pronounced yellow or greenish tint. The fatal cardiac manifestations include severe bradycardia, varying degrees of AV block, and uncontrolled atrial